All right. So moving on to preventive care and health monitoring. So I'm really not a researcher, even though I talked at length about research just now. My main focus is patient care. So I'm a clinical medical geneticist, which means what I want to focus on is how do we take care of patients with these rare disease conditions. And so now I'm going to try to talk a little bit about preventive care and health monitoring in patients with Wolf-Hirschhorns. So what do you actually do once you've diagnosed somebody with Wolf-Hirschhorn? What do we do about it? And I will start with, we don't know enough information to have a great strategy, but I'm gonna go through what we usually do. So so this all starts out with, of course, suspecting the diagnosis, right? Because a lot of times, I think one of our biggest hurdles really in Wolf-Hirschhorn is even suspecting the diagnosis in the first place. So in the United States, we would refer to a genetic specialist at the time of the diagnosis is suspected, because we're the physicians that are knowledgeable, supposedly knowledgeable about Wolf-Hirschhorn, and we would then make the treatment recommendations at that point. And then there's actually making the diagnosis. So when you're suspecting that, what I would prefer, now often they come to me that someone else has actually done the diagnostic test. What I prefer is if someone is worried for this, they would just send to me as a medical geneticist and let me do the diagnosis, the actual diagnosis piece, but that's not always how it happens. So the single best test for 4P- disorders is chromosomal microarray analysis, sometimes called CMA, also known as array comparative genomic hybridization, or ACGH, and it has some other names because, of course, this is, again, the cytogeneticists. I love the cytogeneticists. I know I'm kind of picking on them. They name things funny things, and they call things different things. And so it doesn't just seem confusing, it is confusing. If you're looking at cytogenetic terminology, it is confusing. So there's a lot of different, this gets called a lot of different things. But those are the two most common names for it. And the higher resolution this study is, the better, because you want to pin down the breakpoints to the level of the gene. So karyotype or high resolution chromosomes, so this is the basic chromosome study, I'm going to talk a little bit more about this in a minute, is really quite insensitive for 4P- disorders. And FISH, which FISH stands for fluorescence in situ hybridization, which I'll talk about a little bit more too, is also pretty insensitive for diagnosis. So here's a karyotype or high resolution chromosome study. And I know I already showed you one, but it's still really important. So this is a karyotype that has diagnosed someone with Wolf-Hirschhorn syndrome. So what we have here is, there's your 4P. See remember how I told you that Dr. South, my favorite cytogeneticist, always talks about how the cotton ball is missing on the tip of 4P. So here's our one cotton ball, no cotton ball. So this is a karyotype diagnosing a 4P deletion, and this would be quite consistent with this would be a classical Wolf-Hirschhorn deletion. That this is probably pretty similar to the karyotype of the kids that Drs. Wolf and Drs. Hirschhorn actually reported. And then here, and you can never really see the extra piece, but these are the two other chromosomes that like to be involved in this situation. So what a karyotype can do, it can detect both balanced and unbalanced translocations if they are big enough, which is key, if they're big enough. And also, this is the trouble with this, is because this is a study that's done by growing cells in a special medium and then smashing them open on a slide, and you literally like drop them from several feet and have them land onto a glass slide and then hope they smash open and hope the chromosomes don't fly off the slide, which they can totally do. And then you take pictures and you cut them out. This is very, very operator dependent too. So your karyotype is only as good as the technician who's running the study. That's another drawback of karyotypes. That being said, if you have a really amazing person, you can actually get a lot of data off this study. And until like the early 90s, this was really kind of late 80s, early 90s, this is really all we had. So some of the older patients, this is their only way they could have been diagnosed as kids. So this is the FISH business. So how FISH works is it's a piece of DNA targeted to a very specific region of the chromosome. And it has a little fluorescent dye, so it lights up. So when it hits the spot it's targeted to, it lights up. So here, so this is a chromosome spread. This is what they actually look like. So if you grow the chromosomes, if you grow the cells to get the chromosomes all tightened up so they look like chromosomes and not just big strings of DNA, and then you smash the cell open, this is actually what you get. So that person cut them all out and lined them up. This is what actually, and here the counter stain is blue. So you stain them blue so you can see them. And then there's a probe here that lights up red, and it's targeted to the Wolf-Hirschhorn critical region. And which, of course, as you know from my previous talks, the Wolf-Hirschhorn critical region has a little bit of debate where the critical region really even is, or if we really have a critical region for sure. Anyway, this is targeted to the Wolf-Hirschhorn critical region, and it lights up red. And so this is a fourth chromosome here, and here's the other fourth chromosome, which are helpfully marked with arrows. So here it's lighting up red, and this one is not. See, the tip is not lighting up red. So this means that the Wolf-Hirschhorn critical region, as targeted by this particular fish probe, and that does sometimes is laboratory dependent as well, is not here. So this would make a diagnosis of Wolf-Hirschhorn syndrome. Now, this has a lot of limitations because it will miss deletions that do not include whatever the lab that's running the study has decided is the critical region. So, and as we all know, 4P deletions that don't include the critical region can still be clinically meaningful. They can have impact on the patient's health and well-being. And so I want to know if they're there, even if they don't have whatever the lab decided was the Wolf-Hirschhorn critical region present. So the other piece of this is also a little bit operator dependent as well. This is a tricky test to do. And so you have to have somebody good, you have to have a skilled cytogenetic tech doing this or it won't come out right. Okay, so this is, I showed you a different way that the CMA results can be presented on a previous part of the talk. So this is a sample high resolution chromosome study. This is a CMA. And so here's just a little, again, a picture you can draw for the fourth chromosome a lot of different ways. This is the fourth chromosome. Here's a centromere, so this is 4P. And they have a little line up here to show what region they're looking at. See the little blue line? So these are lots of tiny little probes that are looking at very targeted pieces of DNA that are quite close together along the chromosome. And we're looking at dosage. So 0 is normal. They've zeroed out sort of the normal value. And so what's going on, so this is the tip. Here's the terminal. This is the telomere. And the centromere would be like way over there on that tree or something like that. And we're coming along, and this is normal, 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 normal. Oh, not normal. And so, and then, so they've got these dots, and so then a computer comes in and makes a line. So you see this line is, and this is the copy number here. So there's 1 copy, 2 copy, 3 copy. And so this 2 copy line, which is the same as the 0 on the dot plot, which is normal because you're supposed to have 2 copies because you have 2 fourth chromosomes, right? So you should have 2 copies. And it's going along, boop, drops down to just 1 copy. So this is our deletion. This is how they find the deletion on this study. And the nice thing about this is this gives you a very precise breakpoint. So this is where the chromosome broke to give you this deletion. And so you can find it. And this gives you much better information, and which you can't really see here because they cut off, but down here on the display, there would usually be what genes are involved. So the person who's running this study can actually say what genes were deleted. So this actually gives you information on your precise deletion and the genes. So this is why we like this one. This one also detects unbalanced translocations. It cannot detect balanced translocations. So if nothing is missing or extra, this will be normal, even if it's not in the right place. So a person with a balanced translocation, for example, a parent who might have transmitted Wolf-Hirschhorn because of an unbalanced translocation will not be picked up. Whoops. Whoa, I didn't mean to do that. Okay. But this does, the other nice thing is this will, if you've got extra 8P here, we will find out if you have extra 8P. So the other nice thing, and this is the study that Dr. South used to find out all of the patients that have extra chromosome material as well as missing. Because the extra chromosome pieces tended to be too small to see on this. And of course, this doesn't pick up the extra pieces unless you use a second probe targeted to the extra piece, which would mean you'd have to know what it was before you did the study, which is essentially impossible. So that's the other useful thing about this particular study. So this is the diagnostic test that we want people to use if possible. Okay, other stuff to do at the time you make the diagnosis. So whenever we come in and we think either you have it or you might have it, a comprehensive physical exam, we have to measure, because growth is such a big deal, you have to do really good measurements, weight, height, and measure the head circumference. A lot of, I don't know what is routine here, but in the States, a lot of doctors don't measure the head circumference. And we need to know that. A feeding evaluation is really important because a lot of the kids struggle to eat. And this is a really frustrating issue for a lot of parents. And also that's just really important for the care of children. A detailed developmental evaluation is really helpful. And because neurological problems are such a big piece of Wolf-Hirschhorn, some sort of a good neurology evaluation is really important. Dr. Battaglia recommends an EEG at diagnosis, and he does recommend doing a prolonged video EEG. He likes to hospitalize patients for 3 days and watch them both with a video to see what they're doing as far as any symptoms of seizures, and then correlate that with the EEG, so the things that are stuck all over their head that look for seizures. And so that's his recommendation. And I would tend to concur with that recommendation, even though I'm not a neurologist or a seizure expert, because it's just a good way of getting real good information. A lot of times when we do an EEG in the States, we just stick the thing on for 30 minutes. Well, if the kid's not having a seizure then, and you know, most of our kids can go 30 minutes now and again without having a seizure. So less informative. So it's nice to get a longer EEG. And Dr. Battaglia really says you haven't done this right unless you've done a longer EEG. Okay, other stuff to do. The standard of care from all of the experts is to involve a feeding team. Not all of us have a feeding team, but this is a good idea if you have one. We do recommend a cardiovascular evaluation. Earlier I was talking about how people who aren't familiar with Wolf-Hirschhorn tend to give excessive weight to the heart problems in Wolf-Hirschhorn. That being said, everybody needs a cardiovascular evaluation because the chance of having some sort of issue is actually relatively high. So everybody should have both an echocardiogram and an EKG. And if you can get them to a pediatric cardiologist, that's a really great idea too. Everybody should have their eyes checked, even if they look okay at the beginning, because some of our patients have very subtle problems, sometimes at the back of the eye that you can't appreciate with the basic exam. So I always like everybody to have a good dilated eye exam at least once. Hearing evaluation, really important, really, really important. A lot of the kids have hearing problems. In the States, this would be done by a team affiliated with an otolaryngologist or ear, nose, and throat physician. And the great thing about that is an ear, nose, and throat doctor can also look at, if you have cleft lip and palate, they can help manage that, and they can also help with airway issues if there are any of those. So, you know, I love all my patients to go to an ENT, and I'm not sure how you separate, if that specialties are identical here. And everybody needs to have their hearing checked. Hearing loss is relatively common. And if you miss hearing loss, this is a huge impact on language. And so anyone where there might be an issue with language, you must stay on top of the hearing. This is so big. And so we don't want to miss hearing loss and further drag down someone's language development if there's any concern there might be problems with language development. This is true for any disorder where there's language problems. Gotta stay on top of the hearing. Dr. Battaglia and Dr. Carey recommend using a brainstem auditory evoked response, and they recommend doing it as soon as possible after diagnosis is suspected. Okay, and then this is a relatively new recommendation, but I agree with it. It's good to look at immune function. So checking immunoglobulins or your antibodies, checking antibodies levels. A surprisingly large number of kids have abnormal antibody levels. We don't have any real good data on the incidence of that, but it's a real problem. And then most people recommend lymphocyte subsets as well. That's looking at the cells. So we should check both the antibody level and then the cells, the specific cells involved in immune function. And then polysaccharide responsiveness is also recommended. And to get this done, unfortunately, a lot of times to really interpret this testing, you're going to need somebody who knows a lot about immunology, and those people in the US are kind of hard to find. So this can be tough. And then almost everybody recommends doing a complete blood count, which is actually really straightforward. That's just looking at the cell count in the blood, and that can give you a good understanding of how well the bone marrow is working. Okay. Data within the last 3 or 4 years really suggests that kidneys are very important in Wolf-Hirschhorn patients. A lot of our patients have problems with their kidneys. So at diagnosis, we must evaluate the kidneys, both function and structure. And so we recommend renal function testing and then imaging. And sort of depending, you should at least have an ultrasound imaging, and a lot of people do what we call in the States avoiding cystourethrogram, where they put a little bit of dye in and see if the urine is going the wrong way. And then this is a very new, because of this risk, this possible risk for adenomas, we're suggesting a baseline liver ultrasound so you have a reference point. And I spelled ultrasound wrong. I'm so sorry. Oh, we gotta stop.
Yeah.
Okay.
And I think this is a good place to stop,
Yes.
because then you go to management
And then we're
after
going to
the break.
So we're just finished initial evaluation. We'll move to management.
Yeah.
And I'm sorry I spelled ultrasound wrong. That's kind of embarrassing.
That's okay. Ja. Det er spennende. Det er mye hun har å fortelle oss, så vi får bare henge med. Nå er det lunsjtid her på Frambu, og håper det er litt lunsj for dere som er ute i studioene også. Er det noen spørsmål sånn helt på tampen? Marianne har et spørsmål.
This might be very stupid questions, but
There's no such thing as a stupid question.
when you talk about the differences in immune function, does this kid, do you recommend ordinary vaccination program for these kids, and could one expect proper immunity from such intervention?
This is a really good question. So question was about the immunization schedule. And so almost all of our patients are vaccinated per the routine schedule. We do have a decent group of parents who've decided not to vaccinate their kids in the States, which I know is not unusual in Europe either, unfortunately. One of the big problems we run into with vaccinations in Wolf-Hirschhorn is that the seizures are very fever responsive. And so many of, and the seizures onset in infancy. And so most of our patients have their first seizure after one of their sets of vaccinations, which scares parents a lot. And I have that actually later in my talk with things that parents worry about. So abnormal production of antibodies has been documented. It's not terrible. So, and no one has looked at vaccine responsiveness that I know of, and it actually isn't that hard to check vaccine responsiveness because you just do immunoglobulins, and then a lot of our patients are kids, so they haven't had some of their vaccines, so you can check those, and then you can actually vaccinate somebody, and then you can check titers. But to my knowledge, no one has looked at that, and we do not have enough data on the immune function. We know that kids get more infections than kids with Wolf-Hirschhorn get more, particularly ear infections and lung infections, than persons with a typical chromosome composition. And so we know that there's immune dysfunction, and most people who have been tested have had problems with their antibody levels. And we even have some patients who've been treated with IVIG on the advice of their immunologist, but just it's 3 or 4 people, so just not enough data. So, and of course, we haven't had patients who've been exposed to measles or something to know whether it's really working, that kind of stuff, which I wouldn't want to do anyway. So we don't know. Long answer, give you the long answer. Short answer is we don't know. Most of my patients are vaccinated in the routine schedule. They at least seem to tolerate, other than the seizures because of the fever, they do seem to tolerate it okay. Although several patients have declined for their vaccination because of the seizures triggered by the fever from the vaccinations. And nobody I know recommends not vaccinating patients with Wolf-Hirschhorn. And also, I've run this by, because there's clearly a mitochondrial component here with probably LATM1 and probably some of the other genes. The mitochondrial disease experts that I've talked to all over the world and in the States also recommend full vaccination of all of their mitochondrial patients, despite the fact that mitochondrial diseases are the only place where true decompensation at the time of vaccination has been documented. Despite that, because of the severity of the vaccine preventable diseases in mitochondrial patients, all of the mitochondrial experts I know recommend full vaccination. So, yeah. So we would say My gut would say go ahead and vaccinate.
Okay, thank you.